We're going to get started. Good afternoon and good evening, everyone. My name is Sarah DeFeo, and I'm the Director of Scientific Affairs here at Ovarian Cancer Research Fund. And I want to thank you all for joining us this evening as we continue our webinar series for 2014. And there's been some static on my phone, and I apologize for that. It's on my end. I will keep myself on mute as much as possible, so I hope it's not too big a distraction. I apologize. So tonight's topic is all about chemotherapy and what to expect. Our entire webinar series has been supported by Genentech, and I want to thank them in their generosity for making all this possible. OCRF is the largest and oldest charity in the U.S. funding ovarian cancer research. Our mission is to fund scientific research that leads to more effective identification, treatment, and ultimately a cure for ovarian cancer. Since we made our first grant in 1998, we've awarded over $57 million in research grants. Now, before I get started, I have just a few housekeeping notes to go through. All listeners will be in listen-only mode throughout the presentation. We'll have some time for questions after the presentation, so if you think of a question as you're listening, you can type it into the Q&A box that you see on the right-hand side of your screen. Nobody else will be able to see the questions that you ask, and you won't be able to see anyone else's questions, but I will see them all, and I'll select a few to ask our presenter at the end of the presentation. And there's no need to wait until the end of the presentation to submit your questions. You can just type them in as we go along and as you think of them. I do ask that you try to keep your questions as general as possible so that the answers will be useful to everybody who is listening. With us tonight, we have Kimberly Burns, who is a certified women's healthcare nurse practitioner, and she joined MD Anderson Cancer Center's Department of Gynecologic Oncology in 2004. She obtained her Bachelor's of Science in Nursing at Oklahoma City University, graduating magna cum laude, and then completed her Master of Science in Nursing degree at University of Texas Medical Branch in Galveston. Prior to joining MD Anderson, she worked at UTMB as a nurse practitioner in an outreach clinic focusing on maternal and child health. In her current role, she cares for women newly diagnosed with cancer, as well as those receiving treatment with chemo and radiation. She also works closely with genetic counselors and has participated in the high-risk ovarian screening clinic. She's published many articles and is active in many professional organizations and volunteers at health fairs and with nursing students, teaching gynecologic cancer awareness. And we're very pleased to have her with us this evening. So, Kimberly, I'm going to make you the presenter, and we can get started.
Hi, I'd like to welcome everyone. As Sarah said, I'm Kimberly, and I'm going to talk to you about side effects of treatment. Sorry about this. Okay, so I'm going to talk to you guys about ovarian cancer and managing side effects of treatment. What to expect, intended therapeutic effects, potential side effects and the management of them, and possibly some treatment delays while on treatment. How does chemotherapy work? It attacks rapidly growing cells in our body as well as the cancer cells. The goal is to slow growth or stop the cancer cells from growing or spreading and to use up nutrients needed by the cancer cells. The ultimate goal of chemotherapy is to stop the cancer cells from growing. What should you know about side effects of chemotherapy? Not all patients will get side effects, and it differs from each patient. Some will get a few, some might get all, some might get none. The severity is different from patient to patient, and we do give medications both before and after chemotherapy to help minimize side effects. Once the patient has completed their treatment, most of the time there's no long-term problems post-treatment. The chemotherapy, like I said, it attacks the cancer cells plus the normal growing cells within our body, which include our bone marrow, skin and hair, sex organs, the nervous system, and the digestive tract. Remembering that the goal is to stop the cancer from growing and to alleviate your symptoms caused from your cancer and ultimately cure your cancer or put you into remission if this is a recurrence. Most side effects are temporary, and we can manage them with medications as well as proper measures to teach you while you're on your treatment. The side effects will differ from patient to patient, and it's important that you discuss with your physician all the medications that you're currently taking, even over-the-counter medications, supplements, vitamins, minerals, everything that you're putting into your body. You should discuss with your physician, and you should know that prior to starting anything new, make sure that you discuss this with your cancer doctor as well, specifically over-the-counter medications. Common side effects of treatment are fatigue, nausea and vomiting, changes in appetite, bowel changes such as diarrhea and constipation, neuropathy, which is numbness and tingling of your hands and your feet, weight changes, it can be weight loss, weight gain, insomnia, and some other side effects you can expect are hair loss and low blood counts, which I'll briefly touch on. We'll start with fatigue. There's such thing as mental fatigue and physical fatigue, so it depends on what type of fatigue the patients are having, but causes are obviously doing too much. You definitely will need to adjust your daily routine once you start treatment because you might not have the energy you had prior to starting treatment. And again, remember this is more than likely temporary, and once you finish your treatment, it does get better. Sometimes lack of exercise can cause fatigue, lack of social support, you're not sleeping well, or maybe you just have uncontrolled pain that's not being managed with the right medication and you're dealing with that, or potentially other side effects that are causing you just a lot of fatigue. Depression can definitely be caused with the fatigue, and then just lack of healthy nutrients. You know, if you don't have an appetite or you're nauseated and vomiting, maybe you're just not getting the proper nutrition and therefore it leads to fatigue. Signs of fatigue, you can see weakness in patients. They have difficulty concentrating. A lot of times patients will describe chemo brain. That's kind of the term that they use, and they say they're, forgetful, they can't remember, and they're not sure if it's because they didn't sleep well or is it because of, side effects of their treatment. So they bring that up quite a bit. And obviously they wake up and they're just still extremely tired and they felt like they slept, a good amount of hours, but maybe they weren't sleeping through the night or they were, getting up and using the restroom. There's all kinds of things that could have interfered with their sleep. Patients will complain of lack of motivation. They're very irritable, and even when they do rest, they just feel like the fatigue never goes away. Coping measures for fatigue. The most important thing we tell patients is to prioritize your daily activities. What do you want to accomplish today, and set small goals. We have lots of patients that have big goals. They have huge daily routines and schedules that they really want to stick to. And, it's good to have those goals, but sometimes, certain days of the week, you might not have as much energy as you have maybe in the beginning of the week. So just be aware of that. Ask for help. I know lots of family and friends, people always want to help, but then you feel like you don't want to ask that person to help you. Rearrange your house if you need to. Maybe, if you, like to cook a lot and your cookbooks are further away, maybe move them closer to where you sit most of the time, or, just kind of rearrange things so it's easier for you to get to. Minimize caffeinated drinks. You can still drink them, but be cautious with them. Balance your diet. And, attempt to exercise, even if it's just 10 minutes a day. We have a lot of patients that say that 10 minutes really made them feel well. So try to remember that. Reducing your stress, which is, hard to say how to do this because, patients on treatment, they have a lot of different stressors. And just, lean on your support groups. The next thing I'm going to discuss is nausea and vomiting. The causes of this obviously can be chemotherapy drug related. Some drugs are more nausea causing than other drugs, and generally when you get your chemotherapy, your physician, your nurse practitioner, or whoever will discuss this with you, and usually we start off, telling patients to take their medicine regardless if they feel sick or not, because you want to, prevent it. Patients that are getting chemotherapy and radiation could potentially have more nausea and vomiting because they're getting both treatments. Pain that's not well controlled can cause nausea. Other medications can cause nausea, such as pain medications. Try to avoid taking pain medications on an empty stomach because this can cause nausea and vomiting. Sometimes fatigue can make patients feel nauseated. Maybe there's an electrolyte imbalance, meaning like magnesium's low, potassium's low, which can be caused from the chemotherapy or just not getting the proper nutrition. This can also lead to nausea and vomiting. Certain changes in taste and smell can kind of stimulate nausea and vomiting, and then other medical conditions can cause this as well. Factors that can contribute to nausea and vomiting, like we talked about, chemotherapy, depending on the dosage, the way it's administered. Is it given through your vein or is it given through a pill form? And then the infusion time. So how long does it take for them to administer the chemotherapy into your vein if that's how you're getting it? There's several types of nausea and vomiting. I'm just going to touch on them briefly because there's a lot to talk about them. But there's such thing as acute, which is less than 24 hours after treatment. There's delayed, which is greater than 24 hours after treatment. There's anticipatory, which generally it's due to adverse memories or it's a conditioned response. You walk into the building that you're getting your treatment and immediately you feel sick. Or you see the doctor walk through the door with the white coat on and it makes you nauseated. There's such thing as breakthrough nausea, which generally occurs after the treatment has been given, and even though you've taken a preventative nausea medication, you're still having breakthrough nausea. Then the last one we're going to talk about is refractory, and this usually occurs after treatment. So even though you've taken the preventative medication and you've taken a rescue medication, they both have not been successful at controlling the nausea and vomiting. So it's really important to communicate to whoever you're seeing the day of your treatments, your doctor, and let them know, I've taken all these medications, they're just not working, because we don't want you to be sick, and we have so many options available to us that we didn't have years ago, so patients shouldn't be experiencing severe nausea and vomiting because of all the medications we have. Key factors to help minimize nausea, prevention is key. Communication to your physician, what works for you, what doesn't work. Again, nausea medications can also have side effects, so we kind of have to balance everything out. Some of the nausea medications can cause headaches, some of them can cause constipation, some patients can get jittery, so we have to just kind of weigh all the side effects together and see what we want to do as far as what medications to give. Usually we recommend small, frequent meals, eating slowly, drinking slowly, making sure you're chewing all your food, and just avoiding the foods that kind of upset your stomach. Maybe that you liked pizza before you started treatment, but the thought of pizza just kind of makes your stomach hurt. So, we would say to avoid those. Usually, try sucking on ice cubes or hard candies, that sort of thing, if you're feeling nauseated, like your mouth's watering. A lot of times patients will do this during even treatment or before they come to see the physician. They say this kind of calms them down. Good bowel function is really important to prevent nausea and vomiting. If you're not moving your bowels on a regular basis, meaning, whatever's normal for you. If you get constipated, you definitely can have nausea and vomiting. And then just learn relaxation techniques and how to control nausea. Some people use imagery, some people use just meditation. I mean, there's all kinds of different things people will use. And then, of course, consult a dietitian if, we feel like you're losing too much weight, you've tried everything we've recommended, and so forth. Other causes, obviously we want to rule out other causes because maybe we've missed something. Like I talked about, if you're not moving your bowels, a bowel obstruction would be really important to rule out. If cancer spreads elsewhere to the body, such as the brain, you can have problems with nausea and vomiting. Maybe taking other medications that we didn't know you were taking are interfering and can cause other side effects. You can have nausea and vomiting. And then stomach, if your intestines are really slow and things are not moving through, it kind of gets sluggish. This can cause nausea and vomiting. And then reflux can cause nausea and vomiting. Dizziness can cause nausea and vomiting. Sometimes, if blood pressure is too low, like patients are on blood pressure medications and they haven't been monitoring their blood pressures very closely, maybe it's just that now they're on treatment, they need adjustments with their blood pressure medications, and that could be causing the dizziness, or maybe they have a history of vertigo or, problems with their balance in their ears, that sort of thing. And then obviously stress and anxiety can lead to nausea and vomiting for everybody. The risk factors for nausea and vomiting, usually we'll ask you, have you had chemo before? Have you ever had a history of motion sickness? Have you had problems with anesthesia? Like, we'll kind of ask in the past when you've had surgeries, we'll ask all these questions because we want to focus on, well, this person's been really sensitive to nausea in the past, so we want to make sure we get a jump start and, prevent it. So we'll look at age, and we'll look at, other medical conditions. We'll look at if you have a history of motion sickness, and we'll kind of decide what we feel is best for you and what we should start with as far as what medications to give you pre and post treatment. Important concepts to think about. Obviously, we talked about prevention is key with nausea and vomiting. And then obviously we want to individualize all anti-nausea medications for each patient. So we want to listen to what patients may have taken in the past that didn't work, and we definitely will try something different. We follow national guidelines, but again, you really have to focus on the individual, and it may not be that the national guidelines for this patient are going to work. So we want to focus on what medications they've had in the past and what's worked, and then use those again for the next round of treatment. Know how often to take your medicines, know how much you're supposed to take and when you're supposed to take it. A lot of times you get so much information when you come to these appointments that you can't remember everything. So, bring a pencil with you, pad, write things down, have your friend or family member or somebody write things down, because it's really helpful when you go home and you can look at things. Managing changes in your appetite is the next thing that we're going to talk about. Obviously, this can lead, it can be a cause from nausea and vomiting that patients aren't able to eat. They have decreased appetite. Some patients will have an increased appetite, and then again, this could be related to maybe the steroids that they're getting pre-chemotherapy and sometimes after chemotherapy, because we do give steroids a lot for prevention of nausea and vomiting, and also to prevent any allergic reactions that patients can potentially have. The steroids on board can help prevent this. Again here, eat what sounds good to you. Chew your food slowly, rinse your mouth out in between and after meals. Sometimes patients can complain of taste in their mouth that they can't get rid of while they're on treatment. So, sometimes this can help when you're rinsing before and after meals. Take your medicines that prior to mealtime, like your reflux medication to prevent heartburn, or your nausea medication. And then obviously, if you have a history of slow bowels and constipation, make sure you're staying on your stool softeners. There's usually a lot of support groups and educational classes that patients can take to help manage some of the side effects that you do experience while on treatment. So we encourage patients to get involved with those programs. And then also focusing your attention on other things to try to distract your mind from the nausea and vomiting. Next thing we're going to talk about is constipation. A lot of times patients will present with discomfort in their abdomen, distension, pain. Sometimes they can have a low-grade fever. They're not passing gas. They're not passing their stool. They're nauseated. They've taken medication as directed by their physician, but nothing's working. A lot of times this will lead to, if there's no potential problems such as like a concern for infection or bowel obstruction, the patients will come in, and most of the time they'll need to do some sort of gentle enema, which is the only way to get them to be able to move their bowels. And a lot of times patients will end up in the emergency room center because they're so severely, they have so much distension in their abdomen, and it's really hard and firm, and they'll usually get some sort of enema in the emergency room center. And usually once we get that relieved, then we put the patient on some sort of bowel regimen medications over the counter, such as Miralax, Fiber One, stool softeners, and they'll take that every day so they don't get back in the same situation. Sometimes the constipation can be caused from diet, lack of fluids, medications they're taking like pain medications, or sometimes some of the chemotherapies can cause constipation, or the anti-nausea medications can cause constipation, such as Zofran. Bowel changes we've kind of already addressed this, the constipation. You can also obviously have diarrhea. So causes, again, we've talked about the fluid intake, your diet, medications, stress, depression. Other treatments can cause constipation and diarrhea. And if patients are getting chemotherapy and radiation, a lot of times they'll struggle with the diarrhea because of the radiation, and we will give them, medications to take, such as Imodium over the counter, or prescriptive medication, a little bit stronger than Imodium. Managing your constipation, you're going to want to increase fluids, take your medicines as prescribed to help your bowels continue to move. Sometimes just a little bit of exercise can get movement in your intestine and help with constipation. Everyone talks about well-balanced diet, what to eat, what not to eat. It's hard to eat this healthy diet. We hear a lot from patients when they don't really have much taste, or they don't really have much, appetite. So, do your best and, eat what you can eat. We want you to continue to feel good, and if eating these foods that we recommend don't help you, then we need to talk about what other kind of things we can do to help you. Managing diarrhea, I've kind of already covered. Obviously, you're going to want to avoid anything that upsets your stomach and causes the diarrhea. Milk products specifically. We talk a lot about a brat diet when you're having diarrhea, and that's bananas, rice, applesauce, and toast, which seems to help most patients, but again, it doesn't help everybody. We talk about more potassium-rich foods. A lot of times patients with diarrhea will have low potassium levels, and it's because, they can't stop the diarrhea, along with other electrolytes that they can have low, such as magnesium. We try to encourage low-fiber foods, which I've listed. Sometimes this can be helpful in controlling it. We say call the physician if it persists. Usually after a couple days of, persistence, patients will come in. But, maybe they haven't tried anything. They didn't want to take anything over the counter because they weren't certain. So we talk to them first over the phone and figure out what they've done to try to help their diarrhea, stop. The next thing I'm going to talk to you about is neuropathy, which is another side effect of chemotherapy. And basically what this is it's damage to the nerves. It's usually reversible. One of the drugs that can cause this is Taxol, and it's a commonly used drug with gynecological cancers. And so the important thing of this is knowing that you can expect some neuropathy with chemotherapy. It's usually minimal, kind of tingling for a few minutes. Maybe it's intermittent throughout the day. It lasts for a day. It lasts for a couple days. What we want to know is neuropathy that's persistent. You have tingling in your hands and your feet, numbness, pain in your calves, and it's every day it feels like it's getting worse, or every time you come and see us for that next cycle of treatment, you can't feel the bottoms of your feet, you're having trouble, buttoning your blouse or putting on your jewelry. Those are pretty severe cases, but you always want to keep the communication open as far as the neuropathy, because we don't want to continue to give you that same dosing or give you that same chemotherapy drug if it's really causing this much side effects to your hands and your feet. Obviously, for multiple reasons, risks of fall, injury to yourself, and we just want to prevent that. The symptoms of neuropathy I briefly talked about just a few minutes ago, and it's basically, people describe it as like pins and needles. Most of the time patients will have like a few minutes, few seconds, maybe a day or two while they're getting their treatment, but they always report that it goes away or it stays the same. It doesn't get worse with each cycle of therapy. Sometimes patients will require pain medication because it's just, you know, they describe it as just like pins and needles going up and down their legs. Sometimes it makes their legs kind of restless, and it's just uncomfortable. They've tried everything and nothing seems to make it feel better. We do have patients that do acupuncture, and sometimes patients will say that it does help with their acupuncture. And then there is medications that can be prescribed. Typically, when we see a setting where patients' neuropathy is getting worse, we refer them to a neurologist and get a baseline to evaluate the neuropathy and see, you know, is it truly getting worse, or, you know, what do we need to do? And a lot of times we'll need to make their chemotherapy dose a little bit lower, or potentially even switch to a different drug that causes less neuropathy. With the management, again, it's going to depend on the cause of it. Patients that are diabetic, a lot of them can have pre-existing neuropathy, and so they're already aware what neuropathy is, and then once they get the chemotherapy, it just makes it worse. So those patients we're very cautious with, because even though I said to you it's usually reversible after chemotherapy starts, nerves are very slow to heal, and so it could take up to 6 months post-chemotherapy before your neuropathy gets better. Some of the over-the-counter medications, there's actually like vitamin B6, a lot of times we'll recommend to patients. You know, there's not a quick fix, so they might be on it for a few weeks and they don't really notice any changes. We usually tell patients to give it about 4 weeks. And then prescriptive medication, that's usually when we're going to refer them to the neurologist, because it's not our area of expertise, and let them be evaluated there. Some safety hints with neuropathy. Obviously, if you're having numbness and tingling in your hands and your feet, you know, just good skin care. Make sure you don't have open cuts or anything. We always recommend wearing gloves on your hands if you're washing dishes, or wearing slippers or socks on your feet if you're walking around barefoot, just to avoid getting, you know, some sort of injury to your skin and then potentially getting an infection. You want to make sure you're cautious with walking, and just, you know, we usually discuss fall precautions, because if you're having a lot of neuropathy on your hands and your feet, then we worry about you being able to, you know, hold the stair rail when you're walking up the stairs, or when you're, you know, walking on uneven surfaces such as on the sidewalk. You know, there's nothing for you to hold on to because you don't want to fall and then have some sort of other problem that comes about. And then adjusting the temperatures of water, because if you're numbness and tingling and you can't really tell how hot something is, you know, you want to make sure that you're cautious with water temperatures as well, because you don't want to burn your skin. And some safety hints for neuropathy is, you know, avoiding sudden movements. Obviously, if you're getting up from a sitting position and you know that you're a little wobbly because you have some tingling in your feet, you're going to want to be more cautious when getting up. Use support rails. You know, sometimes repetitive motions can be hard for patients, you know, such as say they play the piano or they play tennis, or, you know, some sort of activity. You're going to want to be cautious with those activities as well, because you may not have quite the feeling that you had prior to the treatment, and so you just want to be aware of that. And then anybody that's diabetic, we obviously stress the importance of good control over their blood sugars. And if needed, they should follow up with their diabetic doctor. The next thing we're going to talk about is with chemotherapy, you can expect weight changes. You can expect weight gain or weight loss. We never know what's going to happen with patients. You know, sometimes, a lot of times initially patients will have gained a lot of weight because they're all the fluid in their belly and the distension that has grown over, weeks or months, and then once they get on treatment, all of the fluid kind of dries up, or they have surgery, and so things get better, and then they start chemotherapy, and their weight comes back down. But then we'll notice, maybe they weren't eating as well during that time when they were not feeling well, and then once they start feeling better, their appetite kicks in, they start eating better, they start eating again, and so then you kind of see the opposite effect. They go into gaining weight again. So we hear that we hear a lot on both sides: weight gain, weight loss. Causes of weight changes could be your diet, you're eating less, you're eating more. Again, the fluid retention that sometimes that usually happens with the cancer cells. And then sometimes when you're on the steroids that I mentioned about, which is a pre-medication that we typically give to our patients for prevention of allergies to any chemotherapy drugs that you've never had before, any drugs in general. And then also we might give steroids to patients after chemotherapy for a couple days to prevent nausea and vomiting. We do hear a lot that patients gain weight because it makes them hungry, so they eat. And then sometimes they can also have like some fluid retention, and they might describe themselves as having a fuller face. So sometimes you can see weight changes with that. And then, again, lack of activity. Maybe you're not as active as you were prior to treatment. Some patients, too, once they undergo a hysterectomy or, removal of their ovaries, their hormone changes in their body are different, and so then their metabolism might be different, and so it's kind of like multiple effects that are causing the weight changes. Managing weight changes, most of the time, it's really hard. We tell patients not to worry about it so much when they're on their treatment, but it's easy for us to tell them that when they're kind of discouraged because they lost too much weight or they gained too much weight. So we just counsel them on monitoring their calorie intake, their portion control, limiting sweets. What time of day are you eating? Are you eating really late at night? Are you eating a lot of snacks? What kind of snacks are you eating? We recommend fruits and vegetables and low-calorie foods. And just, how much, sometimes you'll hear that they drink a lot of caffeinated drinks, so then you want to know how many Coca-Colas are they drinking a day, or, what are they actually drinking? Are they drinking sweet teas? And then kind of counsel them on, maybe cutting back on some of those things and see if they notice changes in their weight. The next thing I'm going to talk to you about is insomnia, so having trouble sleeping, falling asleep, staying asleep, and just restlessness. With chemotherapy, one of the other drugs that patients can most of the time do get as a pre-medication is Benadryl. And a lot of times Benadryl can cause restless leg syndrome. So patients will say, every time I get chemotherapy, I can't sleep at night, So we kind of look at all the medications. Is it the steroids? Is it the Benadryl? What other symptoms are they having? So it's important to kind of make sure that you're reporting all these symptoms to your doctor, because maybe if you're just saying that you can't sleep, but we've never talked about that your legs are constantly moving at night, or they're moving during the infusion because you feel nervous, or, just be aware of all that's going on and try to remember so you can report that to your doctor, so maybe we can figure out what's really causing this lack of sleep. There's multiple causes. Obviously we might not find it right away. Temporary fix, you can take, Tylenol PM, or maybe, an occasional sleep aid medication that's prescribed to you by your doctor. Maybe you're very stressed out, maybe you have a lot of tension. Sometimes just a gentle massage can kind of help with that sort of thing. What other side effects are you having from chemotherapy? Is the neuropathy really bothersome at nighttime versus daytime? Is that keeping you up? Are you drinking too much caffeinated drinks? Are you having some trouble with mood swings? Are you anxious? So we kind of ask, all those questions, and maybe patients have all of those symptoms. So then at that point, we're going to try to figure out which one we want to try to address first, and then address the next issue and kind of go in that order, which one's the most bothersome to them. And a lot of times patients that have restless legs or anxiety, they say, if I could just get this under control, I think everything else would feel better, such as the tension. And decreasing. So with the management of insomnia, again, we're going to want to try to identify the cause, which might be several different factors. Sometimes we'll recommend to patients to do chart sleep schedules and kind of when they're awake, when they're asleep. You know, are they eating prior to bedtime? Are they drinking, you know, a caffeinated drink before bedtime? What do they do before bedtime? Like, what's their regular routine? Sometimes different distractions in their bedroom can keep them up. You know, do you have an illuminated clock that's like bothering you now that used to not bother you? Maybe we need to turn that away from you or dim it. You know, are you on a good sleep schedule, or, you know, 3 nights of the week you stay up really late and the other nights of the week you go to bed early? So kind of try to modify your sleep schedule and see if that helps. If you're taking a lot of naps during the day, that can lead to insomnia at night. And then, you know, try to exercise a little bit, you know, if you can tolerate it. It's hard to do all this, but, you know, we'll try to, you know, maybe set one goal and see if that helps. Is your pain under control? You know, what about your moods? How are your moods? And then, you know, we can talk about short-term sleep medications. And again, you can think of other techniques such as, you know, imagery, behavioral or cognitive techniques. If everything else we try doesn't really work, or maybe, you know, you're the type of person that wants to try some sort of alternative approach versus taking another medication. You know, everybody's different, so we kind of talk about all options. So basically, that's the end of my talk, and I'm ready for questions.
Great. Thank you so much, Kimberly, for that wonderful presentation. It's very comprehensive, very helpful. We have a few questions. Let's see. First question is, well, this is not related to chemo. I'm struggling to deal with the side effects of early menopause after my surgery. I'm hesitating to do hormone therapy, but what do you think? Do you have any suggestions?
So typically, depending on what type of cancer you have, most of the time in gynecological cancers, we don't recommend hormones, but again, it depends on what type of cancer you have and what age you are. There are non-hormonal medications that we can prescribe to you. One of the most popular medications that we're prescribing right now is actually an antidepressant that's called Effexor. It's E-F-F-E-X-O-R. And it's been studied with women with hot flashes and that sort of thing. And sometimes postmenopausal women will have mood swings and depression and, you know, everything on top of maybe their cancer treatment. The medication is usually prescribed at a very low dose, and then we can go up on the medication after 4 weeks if we don't feel like it's really doing much for you. And the patients that are on it and that it works for, it works well. It's not perfect. They might still have occasional hot flashes, but it's not impacting their quality of life like it was beforehand. One of the side effects of the Effexor, because it is an antidepressant, could potentially be some weight gain. So usually when we tell patients that, they're like, I think I'll just, you know, deal with the hot flashes. I've already had weight gain and I don't want any more weight gain. But it's a potential side effect, so it's not a for sure that you're going to gain weight.
Okay, thank you. Another question is about, she says, I'm having continuous abdominal pain after receiving IP chemo for my ovarian cancer. What's the best way to deal with this?
So intraperitoneal chemotherapy, one of the common complaints from this treatment is pain, because if you think about how this medication is being administered into your abdomen, you know, the fluid's going in and they're kind of moving you throughout the treatment to kind of get the fluid, the chemotherapy in your abdomen to be distributed throughout your abdomen. However, you're still more than likely going to experience pain afterwards, and you know, a little bit of movement is good, especially during the infusion, you know, repositioning and stuff. Taking some pain medication. Most of the patients that we have had on intraperitoneal chemotherapy definitely need the pain medication. Then they get into nausea and vomiting because of the pain medication, and they're not eating well, and then we get into constipation, so we have to stay on top of like all these other things. But I haven't had anyone that says they don't have pain with the intraperitoneal chemotherapy. Most of the time they have the pain and we just try to manage it with pain medication.
Okay. And I think our last question is somebody says, I have a major case of chemo brain. I feel like I have problems remembering and recalling information. Do you have any suggestions, and will this ever get better, basically?
Yeah, chemo brain, unfortunately, is a common symptom that we hear from patients, and even once their treatment is completed, they have problems. It's easy to tell them, try not to get frustrated. Lots of people are having this. We sometimes do send them to the neurologist just to make sure that there's nothing else that we're missing. And we kind of just recommend, keeping a little notebook with them so when they come, they have their questions already written down and they're not frustrated because they forget what they were supposed to ask us. And then usually they'll have a friend or a family member that kind of helps. Well, do you remember what happened last week when we did this? And, everyone kind of just helps. And I think the other thing is just to take your time in trying to remember what you're wanting to remember, because once you get frustrated, you're so frustrated that you can't even come to your thought. And, it takes time if you're working during treatment or you're going back to working and you have, a job with a lot of thinking and you're on the computer and you're having to be quickly moving fast throughout the day, it does take time to get back into it. Most of the time, patients always have some sort of slight little chemo brain post-treatment. It does get slightly better with time, but I would say most of the patients I've seen in the years that I've been doing this, they always have a little bit of chemo brain.
Okay. And actually, we just had some more questions come in. 2 people just asked basically the same question. I suffer from joint pain like arthritis that I did not experience prior to ovarian cancer and chemo. Is this normal, and is this something I should be concerned about?
So we do see patients that have a new onset of arthritic symptoms with treatment, and they said they never had them before. Could it be that maybe it's neuropathy and it's just in your joints? One of the side effects of chemotherapy is like flu-like symptoms overall, and you can have this joint kind of arthritic pain. What we generally recommend to our patients, if it's progressive and it's not getting better, is we usually refer them to a rheumatologist, and the patients will get worked up. And most of the time, they do have a new onset of arthritic symptoms that, for some reason they're caused from the treatment.
Okay.
And, patients, they do, they'll treat them for their symptoms, sometimes just taking like an occasional leave on a daily basis, or, Tylenol, or, some sort of over-the-counter arthritic medication helps control the discomfort, and then maybe a little bit of exercise and movement kind of minimizes it, but, they still complain of just this kind of achiness.
Another question is, Taxol has given me bad GI side effects of constipation and nausea. Do you know whether moving to a new delivery agent, such as Abraxane for Taxol, would improve the bad GI side effects?
It depends. If you had like GI symptoms before surgery or before chemotherapy, and you're on like some sort of medication to prevent or decrease like the acid in your stomach, maybe it's just that you need to switch to a different medication because your body's just kind of become too used to that medication. Diet control, like is certain foods that you eat setting off this, spicy foods. Have you seen a GI physician? Is there something else going on? Like, do you have an ulcer? Is there another medical condition that could be contributing to this? Patients will have can have this increased reflux while on treatment. Most of the time after treatment, it gets better and they're treated with some sort of, medication to take, and usually we do like a 90-day prescription, and we see if their symptoms are better, and if they're not better, then it's time to get maybe an upper GI where they actually scope your esophagus and make sure there's like nothing going on in your esophagus that we're missing.
Okay, great. I think those are all the questions we had. So, Kimberly, I just want to thank you again for your presentation, and I want to thank everybody for calling in today. Our webinar series continues next week, actually, on April 24th with a special presentation by Dr. Doug Levine of Memorial Sloan Kettering Cancer Center, who will talk about some exciting new findings he has in small cell ovarian cancer. Please take a minute to fill out the survey that will appear on your screen at the end of this event, because your feedback and suggestions are always very helpful to us. And for more information about OCRF, you can always visit our website at www.ocrf.org. So thank you very much, everybody, and have a wonderful evening.